Hello, everybody, and welcome to GHAPP MASLD MASH Community Network. My name is Christina Hanson, and I am a nurse practitioner, and I'm going to be taking us through this deck today on MASLD and MetALD. You can use this QR code to register for this meeting if you have not done so already. So let's go ahead and jump in talking about MASLD and MetALD. The first thing we're going to do is just introduce a common case scenario that we all see in our day-to-day practice. This is Ashley. She's a 52-year-old woman. She was referred for evaluation for findings of mildly enlarged liver on an ultrasound with increased hepatic echogenicity consistent with steatosis. And she feels well without complaints. So this is some of her patient information. She has a past medical history that includes some metabolic disorders. She has hypertension, hyperlipidemia, PCOS. Remember that polycystic ovarian syndrome is commonly associated with fatty liver in our female population. Actually had a patient last week who came in honestly for a different indication, but had morbid obesity, PCOS, and I actually recommended screening that patient for fatty liver. I think they came in for GERD or something else. So remember, when they have some of these cardiometabolic risk factors, you want to think about screening these patients. On physical exam, she had a smooth, non-tender liver edge palpated. Her social history, she actually is endorsing 2 glasses of wine per day. Medication-wise, she has some medications for her hypertension and amlodipine. She's on a statin for her hyperlipidemia, is taking a multivitamin, and of course, once she heard about her liver fat on ultrasound, she started milk thistle, and we know we're going to have a conversation around that and the real lack of any validated data that support that this is a benefit. So I always tell my patients, you don't need to go and jump on milk thistle, save your pennies. We really just don't have a lot of good data that support that that is of benefit. So looking at her vital signs, so she might be having a little bit of white coat syndrome, or her hypertension may need a little bit of attention because her blood pressure is a little up at 140/78. Weight 161, she's 5'2", so her BMI comes to around 30. We're looking at some of her blood work. We see that her AST is a little higher than the ALT, but her liver tests, her transaminitis, shows this profile of AST greater than ALT. And remember, when we do see that ratio, you think alcohol, heavier alcohol use, or if the AST is greater than the ALT, another scenario would be advanced liver disease, liver fibrosis to the point of cirrhosis. So when that AST is greater than ALT, think alcohol or cirrhosis. Her T-billy is right at that upper limit of normal. It's actually kind of high, but high normal. So that does put up a little bit of a flag. Hemoglobin A1C, platelets, so those are in the decent range. Triglycerides a little bit high normal as well. So we're thinking about what we can maximize with management of our comorbidities. We did do a fibrosis assessment with elastography. We see her FibroScan results here, kilopascals at 11.4, and that ends up being in the range of 9.6 to 12.5, which is significant fibrosis or stage 3. And then she has a CAP or controlled attenuation parameter score of 310, consistent with steatosis grade of 3 or severe steatosis. So severe fatty infiltration and advanced stiffness consistent with stage 3 fibrosis. So we have this change in the nomenclature of fatty liver disease. What we knew as NAFLD or NASH now falls under the umbrella, of course, steatotic liver disease, as metabolic dysfunction associated steatotic liver disease, or MASLD. And that really reflects better the actual nature or natural history of the disease with metabolic conditions, whereas a non-alcohol or alcoholic liver disease was really kind of a diagnosis of an exclusionary diagnosis, somewhat obviously stigmatizing, and didn't really match the actual, as I said, natural history. But again, under this umbrella are other forms of steatotic liver disease, and MASLD with increased alcohol intake is what we call MetALD. So obviously they have metabolic conditions, but then they have increased amounts or heavier amounts of alcohol. And when we look at more of the MASLD predominant, that's when we're looking at alcohol intake per gram per week. And weekly intake of 140 to 350 grams for female and 210 to 420 grams for male. And you can also break that down average daily intake, 20 to 50 grams for a female or 30 to 60 grams for a male. And at the higher end of those alcohol grams spectrum is when it becomes more alcohol liver disease predominant. So MASLD predominant or alcohol liver disease predominant fall under that MASLD MetALD nomenclature. And then beyond that, if patients really don't have any cardiometabolic risk factors, they don't have conditions of the metabolic syndrome, but heavy alcohol use, that's where it is predominantly alcohol-related liver disease. And then specific other etiologies that can cause fat in the liver, drug-induced liver injury. There are many medications that actually can contribute to the development of fat in the liver over time, such as tamoxifen, amiodarone, methotrexate. Patients are on long-standing steroids. So some of these medications, we have to remember to be asking our patients about these, especially if they don't meet criteria for metabolic disease or alcohol. Monogenic diseases, miscellaneous, so other diseases like Wilson's disease, other inborn errors in metabolism can fall under this, and cryptogenic steatotic liver disease, which in the end, we don't have any really obvious source for the fatty liver disease. All right, so let's talk about equivalences between alcoholic beverages. And actually, I found this really fascinating myself. When I'm talking a patient, what's a one drink per day? I talk about this 12 ounces of a beer, 4 to 6 ounces of wine, or 1.5 ounces of hard liquor, distilled spirits. That's kind of how I talk to my patients about what kind of a standard drink is. And then when you look at the actual alcohol content, it's kind of fascinating. So in our patients who are beer drinkers, 5% can be found in a 12-ounce beer. And then when we look at table wine, about 12% alcohol content in that 4 to 6 ounces of wine. And then when we get even higher up the spectrum, when we have our brandy drinkers, or certainly those that do distilled or pure alcohol, so your vodka and such, you're getting up to 40% alcohol content in a single drink. So some of the key pathogenic mechanisms, we certainly can have dual etiologies contributing to the development of steatosis in the liver. Obviously, risk factors of metabolic conditions, so insulin resistance, that's kind of that overarching factor, and that's where all our metabolic conditions fall under, as well as our supersized diets, unhealthy food, sedentary lifestyle, and certainly genetic or epigenetic factors can make us more susceptible, and alcohol intake. Also contributing to oxidative stress and cell death, impaired lipid handling. And then when we look at how NAFLD and alcohol-related issues cause dysfunction at the intestinal microbiome. So again, increased ethanol production, microbiome-derived products, causing accelerated fibrosis development and disease progression. So there can be multiple hits contributing to the development of fat in the liver. This is drivers of liver disease and looking at when you have multiple factors contributing, how the risk of decompensation increases over time, and you bring in that fibrosis stage on top of that. So if you kind of look from left to right, we look below and see disease drivers. So we've got our cardiometabolic risk factors, and of course, like a pancake, the more cardiometabolic diseases you have, that increases risk. We take into account genetic risk factors, and we're not doing a lot of genetic testing. We recognize that PNPLA3 and BOAT7 are some of the more common genetic variants that are associated with development of fatty liver. And then at the bottom there, you see alcohol use. And as those grams increase, female to male over time, along with those other risk factors, and taking into account stage of fibrosis, from minimal to no fibrosis at a kPa of 5 up to 15, those 5-year risks significantly jump the more that you add on. So detecting alcohol use with biomarkers. So we've really, over the years, relied on self-reporting, and even into more recent studies for fatty liver and medication approval, including the approval of Rezdiffra. Really, we were relying on self-reporting. We really haven't historically in clinical trial or maybe in our kind of day-to-day clinical practice been using a lot of biomarkers. Patients will go into the ER, they'll get, maybe ethanol testing on blood work in the hospital, but we have only more recently started using biomarkers in our clinical practice, and now starting to see more of that coming into research. So we've got patients who have metabolic diseases. So that's kind of looking at the left of this. And this was a study looking at alcohol biomarkers, and comparing to questionnaires like Audit-C, which you're all very familiar with, and looking at other types of alcohol measurements that we look at. So MCV, so we see high MCV, MCH, GGT. These are different lab markers that can be elevated in the setting of alcohol use. Carbohydrate deficient transferrin, we're familiar with CDT. But then looking at ethyl glucuride tested in the urine or the hair, if you can believe it. Some of you might be familiar with that. That was somewhat of a new concept for me. And don't ask me how, as we see this little scissors in the hair there, exactly how they process that, but you can actually test for this component, obviously in urine, but also in hair. And so comparing that to an audit questionnaire. So you have the patient with metabolic risk factors, testing for higher amounts of alcohol with these types of biomarkers, and comparing to a questionnaire like audit versus other lab markers. And basically what they found was moderate to excessive alcohol consumption in a little over almost 29% of patients with NAFLD, or 25% in those classified as metabolic associated fatty liver disease, and found that the optimal diagnostic methods were actually using hair or urine plus audit. So MCV, GGT, some of those other lab markers were not as sensitive, but this study came out recommending the consideration for using these other forms for alcohol use. So what are gaps in the assessment of metabolic and alcohol related, or MetALD? So we've got evidence of metabolic dysfunction based on their comorbidities. If we have a patient with just isolated high blood pressure, triglyceridemia, if they have this, but have no evidence of alcohol use, again, by self-reporting, this is a patient that's going to be classified more in the MASLD. But if they do have evidence, self-reported evidence of alcohol use, you can consider additional biomarkers. And probably the most common that we're using is PEth, or phosphatidylethanol testing, which is a direct biomarker of alcohol in the blood, and can be extremely sensitive. It's what we call the hemoglobin A1C of alcohol testing. It can measure alcohol use up to 3 to 4 weeks. So in those patients, consider PEth testing that maybe have an undisclosed alcohol use. And depending on where they break down, and we have very specific recommendations now around that we talked about earlier on. But for our female patients, when we're looking at 140 to 350 grams in a week, or 210 to 420 grams in our male, this is concerning for, or obviously greater, for MetALD. And if there's a significant amount more, that's where we're going to call this patient more alcohol predominant. But if they have those metabolic conditions and they're falling in these ranges of MetALD, then we're going to put them more in that category. And then, of course, excluding other differential diagnoses is still important, talking about other potentials. We always want to rule out other underlying liver conditions. Remember, when we have a patient that comes to our practice with elevated liver tests, with maybe steatosis on imaging, can they have more than one thing going on? They can have MetALD. So we talk about the alcohol. I hate to say it, but I don't always trust self-reporting. And we've seen this in studies. And so really, when I talk to my patient, I say there's going to be a workup that I'm going to do. that basically looks for and rules out any other potential underlying liver condition. Underlying meaning you wouldn't know it unless we looked for it, because yeah, you can have fatty liver and you can have, a virus, you can have hepatitis, you can have iron overload, you could have some kind of genetic or autoimmune disease of your liver. And PEth testing is a part of that workup. It's a standard part of our workup. So that's going to be something that we're also going to be checking. So everybody gets a PEth test that comes in with fatty liver disease or elevated liver function tests. We want to make sure we're not missing some other etiology or coexisting. All right. Let's see if I can move on. Oh, they want to highlight everything. Okay. All right, so we, for Ashley, went ahead and ran our PEth test, and she fell in at 120 in the range of moderate to heavy alcohol consumption. So really less than 20 is considered abstinent or very low alcohol consumption. 20 to 200, moderate to heavy, and greater than 200 on that range. And nanogram to liter is excessive alcohol consumption. And I know you've seen it. I have seen it. We have patients that come up in, the 1500s, excessive alcohol consumption. And again, that's that 3-week snapshot. I think we're going to talk a little right here. This is the one we're going to talk about when we're measuring blood alcohol content, or you can see this on the left here compared to PEth. And this is looking at the mean time hourly. Look at how quickly after one single binge, if you will, the half-life, PEth was detectable for 3 to 12 days after that single binge. But our blood alcohol will spike, and then after 2 hours already starts to drop. But that PEth can be detected for, again, up to, even 3 to 4 weeks. And there really on the right here was no significant variability based on gender or BMI. So this was a study looking at patients with a baseline metabolic condition of being overweight or obese, so patients with excess weight. In the end, 617 patients were enrolled, and either by self-reporting heavy alcohol consumption that would meet criteria for MetALD, so in our females and males, or those that maybe had underreporting PEth testing captured those patients greater than 25 or equal to or greater than 25 in the female and male category. And what they found in patients who, again, had a baseline metabolic condition of overweight or obesity, 97 or 15.7% were suspected or felt to be at risk of having MetALD based again on that description or the PEth testing. So again, patients with baseline obesity with that comorbidity in this particular study, almost 16% were also felt to be at risk for MetALD. All right, so talking about Ashley, we talk about looking at her medical history. So we know that she has metabolic syndrome, metabolic metabolic risk factors, also endorses at least 2 glasses of wine or more based on her self-reporting as well as her PEth testing. So let's look a little bit more at heavier alcohol use and some of these comorbidities. So this was a 32 randomized controlled trials involving over 760 patients. And what they found in this study was that alcohol actually had a biphasic effect on the blood pressure. I won't get into the weeds on the right here, but you can see that systolic versus diastolic and the breakdown of hours. It actually showed a decrease in blood pressure up to 12 hours after consuming that alcohol. But then as time went on, greater than 13 hours or longer, the blood pressure actually increased after that alcohol consumption. So there seemed to be this biphasic effect where initially it actually they had some hypotension or a drop at least, maybe not by standard hypotension. But then as time went on, they saw an increase in that blood pressure. And how about hypertriglyceridemia? So looking at mean plasma triglyceride concentrations over a 10-hour period after administration up to standard drinks of alcohol drinks versus water. And so when we look at patients that had a baseline hypertriglyceride versus none, so no dyslipidemia or hypertriglyceridemia. And that's what we're looking at on the left. So it's kind of harder to tell, but we see the differentiation between those in the water are kind of that gold versus those with or without triglyceridemia in the kind of the navy blue. and those with alcohol use that are circles versus the squares. But basically, you can see higher amounts of plasma triglyceride in the patient groups, whether they had hypertriglyceridemia or not, but those that actually consumed alcohol had higher plasma triglyceride levels over time. And this was looking at a 10-hour period after administering those standard drinks. All right, so coming back to Ashley, this is her patient profile again. So we see her labs, her medication, her alcohol use, and her key exam again, looking at her fibrosis score and understanding her history of alcohol use and PEth testing. We diagnosed Ashley with MASLD predominant MetALD. So some of the questions to think about, to ponder on: what are our current treatments when it comes to our patients with metabolic dysfunction associated steatotic liver disease, but a heavier amount of alcohol? Well, certainly diet and lifestyle is still the cornerstone. We still want to be talking to our patients about diet. And when I talk to my patients, I say I don't necessarily espouse to one being better than another, but I do say Mediterranean diet seems to have the best data in the literature. Clearly, we want our patients continuing to work on exercise, even in the absence of weight loss. Regular aerobic cardiovascular exercise can reduce steatosis in the liver without any changes on the scale. That's something I try to encourage my patient with, but certainly getting that BMI down, getting that weight loss down, talking about the weight loss pyramid like we love to talk about, and the ability to reduce steatosis and even fibrosis. And then, candidacy for resmetirom. There's no specific discussion or language in the actual indication for resmetirom around alcohol use, heavier alcohol use or not. Knowing how many patients in the study likely were imbibing a little bit more than they were actual acknowledging or reporting. There was a lot of underreporting. This is again going to be a discussion clinician to clinician about use of resmetirom. But again, it's not contraindicated to use Rezdiffra in the setting of MASLD with MetALD. But certainly we want to be having a conversation with our patients about tapering down and tapering off of alcohol. Remember that Ashley is stage 3. Stage 2, you can split the atom on when it comes to alcohol and look at studies of a patient who's never had a drink in their life to once a year, to once a month, to once a week, to multiple times a week, and just the ill effects over time, the significance or lack thereof in patients who never versus do drink. And you can really get that into the weeds about it. When you're having any degree of scarring in the liver, I start to have that conversation with patients. Yeah, if you never drink, that's going to be the best scenario, right? But when you start to have fibrosis, this is something that's going to be, significantly more important that you avoid alcohol completely. And at stage 3, this is something we want Ashley to completely stop. And does she need to consider hepatocellular carcinoma screening? Do we need to do HCC screening? I tend to do that with my stage 3 fibrosis patients. There can be some data around the risk of developing HCC even in our stage 3. And again, we're basing this on BCTE or FibroScan showing stage 3. Liver biopsy is an imperfect gold standard. But if we did a liver biopsy over here versus over here, could it be possible we captured a stage 4 on that? So this is something, and we know that there are limitations with every non-invasive test for fibrosis or NIT. So this is somebody that I would be a little bit more cautious with. And at stage 3, I would do HCC screening with imaging every 6 months, plus minus alpha fetoprotein, depending on what you guys do in your practices. So what is the ideal MetALD definition for clinical trials? So we're starting to see this being put into clinical trials. Well, we want to really be able to base it on objective biomarkers, not subjective. We really need to overcome that underreporting that we have in our patient population for alcohol use, and to be able to standardize the assessment of any recent alcohol use, and certainly to certify abstinence in our patients. We want to ensure that drivers of liver disease are present. We just talked about how alcohol can actually have effects on triglyceride, effects on hypertension. So considering more than one cardiometabolic risk factor and ensuring that these are actually persisting after stopping alcohol use. So when we have patients who are drinking daily, how much of that alcohol use is driving that hypertension or hyperlipidemia? And when they become abstinent, do we see that persistence of that cardiometabolic risk factor? And then considering the exposure to risk factors, so a fulfillment of criteria for MetALD during the last 6 to 12 months. So in conclusion, we have that new definition of MetALD, so metabolic comorbidities plus increased alcohol, and specifically based on these numeric values of grams in our female, 140 to 350, and 210 to 420 for women and men respectively. Clinical criteria can definitely underestimate MetALD, and PEth is probably the biggest alcohol biomarker that we're using these days, but we talked about some of the others that are in study and can be utilized. And ensuring that drivers of liver disease are present, so reassessment of metabolic dysfunction over time. We want to consider that there's been adequate exposure to that risk factor, and certainly criteria for clinical research should facilitate an objective MetALD diagnosis that allows comparisons among our different sociocultural realities. So thank you for listening. This is a QR code that you can use to visit GHAPP MASLD MASH Community Network for additional disease state education and Rezdiffra webcast. Thanks for joining.